sequel number 3, Bahubali 3 coming in, possibly. But since I'm a man who has conviction for DCB, I think it's going to come from the heart. So, apart from let us start, my topic is basically clinical application, real life cases, which actually, we have been seeing in the last two or three talks. So this is the approved indication, an ISR, which we all know. This 46-year-old male, PCI, 1 year back, for a borderline lesion in the LED for a positive, asymptomatic positive TMT. 6 months later, came with angina for the first time, ISR, and a second stent implanted. Again, 275 in the proximal LED without imaging, comes back again now with a non-STEMI. And, he has, as you see, he has diffuse ISR. There is, lesions both proximal and distal to the stent as well. Imaging shows that the stent is grossly underexpanded, grossly undersized. You see the diameter is 2.3 in the proximal LED. There is some new NIH. There is disease both in the proximal and the distal part of the stent. So Wolverine at high pressures proximally and at nominal pressures distally. And, about 3 millimeter NC balloon at high pressures, you are expanding 2 layers of stent, prolonged dilatation. In the proximal, in the distal and the mid segment, you get good areas, more than 6. Proximally, we are not very happy. And as you see, the areas were 5.5, and the artery proximally to the stent is around 3.5. So went with a 3.5 NC again, and this time we were happy. The areas were looking around 7. So remember, in DCB, before you actually deliver the drug with the DCB, which you're doing at maybe 6 or 7 atmospheric pressures, we need to prepare the lesion extremely well. That's the most important. It's painstaking, but you have to do that to ensure good results. Another second indication is small vessels. Obviously, you would avoid 2.25 and 2.5 millimeter stents, and DCB is a better option. Now, these are the expanding indications which we have already seen. And here again, for all these indications, we are going to see cases for de novo large vessels, bifurcation, ostial, diffuse, hybrid, and so on, Like this was a 28-year-old young female, unmarried, a tight lesion, ACS, tight lesion in the proximal LED. We started with a cutting balloon, NC balloon, seemed to have a very good result, dilated again with a 3.5, and then we got tempted to use a DCB because it was like a stent-like result. This was after 3.5 DCB. Another patient, bifurcation disease, OM1, OM2. OM2 is a small vessel, so plan to do a DCB for this OM2, and we dilate, and we thought we'll dilate and then see what we can do. A 2.5 NC balloon dilatation. Angiography, it looked good to go. It was looking good to go for a DCB. But then IVUS showed that the vessel here is not 2.5, it is actually more than 3. Here it's 3.2. And here, we had not prepared the lesions well. There were no significant dissections, as we discussed. So we took a Wolverine and then a 3 millimeter balloon at high pressures, and now we were happy. You have cuts, you have a medial dissection, And I think if you have a medial dissection, your patients are going to do better. And this is after a 3 millimeter DCB, and you get a stent-like result. So preparation is the key when you're doing large vessel. I was talking of dissection. In fact, this is a recent Japanese study which showed that the predictors of target lesion failure after DCB PCI, one was if you do not have medial dissections, the patients are likely to come back. So meaning thereby that medial dissection is a predictor of better outcomes. So you should aim for dissections when you're doing a DCB. Again, very important is bifurcations. Bifurcations, you reduce metal, and could we do bifurcations with DCB in both vessels? Let's see. This 62-year-old male, bypass surgery done, osteoproximal, heavily calcified disease in the LED and circumflex. We planned rotablation to both vessels, and then DCB to circumflex if possible. We did rota to circ, open it up. There were some dissections. Physiology was negative in the circ, so ended with a circ DCB, and then rota and stented the LED to get this result, So again, dissections here, they look long enough, but then believe me, as Dr. Florim also showed, that dissections, they do well, they heal, and they don't get you back in the night, in the middle of the night for a repeat procedure. Another patient, ongoing angina, 2 bifurcations here. Now, this D1 is a long disease, so we did a mini crush here, but for the second lesion, we did a DCB and a final kissing to get a good result. So here we avoided another metal. Another bifurcation, circ, we prepared both lesions with Wolverine, and then a DCB in the circ and a stent in the OM1 to get this result, So it's the bifurcation with single stent, In fact, since we have been using DCBs, my 2-stent technique has actually, 2-stent has actually gone down very significantly. Now, this is a case, which is a dilemma case, There's a stent here, some ISR, and now you have osteoproximal tight disease at the LED, and there is a tight disease at the ostium of the D1, which is a very large vessel dividing to a 3 millimeter vessel. So how do you treat this? Ideally, maybe 2-stent strategy, conventional thought process. But, we prepared with cutting balloon in both the vessels, and we got a real good result post-cutting balloon in both the vessels. So we sequentially applied drug DCB to this 3 millimeter DCB into the D1 and a 3.5 DCB from left main into the LED. So proximal LED bifurcation stenosis done only with DCB without using metal. Because here there was a stent up till this place, so we would have ended up, having 2 layers of stent at that point. So this was treated purely with DCB. So you need to actually, these are, and that Des would remain for his life from left main into the LED. So we have avoided that metal into the LED. Again, these are dilemma cases, ostial disease, ostial circumflex, ostial D1, isolated disease. Open the artery, cut, dilate, and do a DCB. Again, long diffuse disease, Now, this patient is 54 years now. 22 years back, when he was 36, we had put 1 stent into the LED. The stent is up till this place. Now he has some ISR in the distal part of the stent, and you look into this LED. Right up to the apex is diseased. The easiest thing is to put 240, 44 long stents, which we see very commonly, which really pains me to see the entire artery with the stent here. And but how do you treat it? You have to be slow, steady, take a lot of time to prepare this vessel 2.5, 2.75, 3 NC balloons, cutting balloons, and again a dissection seen here, but again they really don't close. So you see a good medial dissection, good areas. We use 3 DCBs in tandem to get this result. Now it's a long area that has been treated. This patient may come back later with some areas. So if he comes back, he'll come back usually with good, there'll be late lumen gain in this patient. And even if he comes back, he will come back with a focal area of restenosis maybe, which you could do a spot stenting. Like we did in this patient, This patient came to us with interval MI, and this was his LED. The LV function was around 30-35%. We were not sure of the viability. So we opened up long disease. We just did a DCB, and we called him back after 6 months to treat his right coronary artery. And we just took a shoot for the left. You see, it's much better now. And this area, it was not looking good. We just did a spot stenting with that 15 millimeter balloon in that area after 6 months. Again, and the LV had improved to 50%. So you can always come back to a spot stenting for an area which you have done a DCB earlier. Again, hybrid approach is something which is, being talked about a lot, and there are a lot of studies, by this we mean you stent the proximal large vessel and you treat the distal vessel when you have a long disease with a DCB. Like this was a patient, a CTO. It took a long time to do the CTO, and once we did that, we realized that the distal vessel was diseased, so we stented the proximal and DCB of the distal vessel to get a good result. Again, calcium is one place which Florim was so, used DCB, and I was so happy to see that. And the more you all see, the more you all get convinced that DCB is the treatment when you're dealing with calciums at, in some places. ACS, heavily calcified circ ostium, we tried to do imaging, it wouldn't cross the circ ostium. At the circ ostium, the areas look good. So what we did was got a guide extension, just did a balloon and a DCB. not a perfect result, but a better result than trying to do something with a stent there at the ostium of the circumflex. This patient, we had done a primary angioplasty for his circumflex. Now he has long, heavily calcified disease in the LAD and a ramus, large ramus. When we did this, we just, to assess how bad the calcium was, we wired this and tried to put a 1.5 millimeter balloon. It was a balloon uncrossable lesion. So we got him back. We did, orbital atherectomy. We have realized over the, last month since it is available that, orbital atherectomy possibly gives us better areas, does better plaque modification, better atherectomy than a rotablation. So we did orbital atherectomy in the ramus and in the LAD. Here, as you see, in this ramus, there were no landing zones. There's no way you can do any bifurcation strategy here. So this was a case where we did a DCB into the ramus and stented from here into the LAD. So you can do safely DCB even after rotablation, after atherectomy, and in calcium, long 2.5 millimeter stent in a calcified vessel is never going to do very well. It's going to come back. Now the upcoming role is also with patients who require anticoagulation. You can de-escalate to single antiplatelet very early in DCB patients. Diabetic patients, where you want to avoid stents, very large vessels, ectatic arteries, you can do a DCB, and avoid stents where stents would not get opposed very easily. Now, this was again an interesting patient. We fixed the LAD in an 86-year-old male, and we dilated the circumflex, and we tried to get a stent down there. After even good dilatation and preparation, the stent wouldn't track down. Option was to take a guide extension. We thought, we just delivered a drug-coated balloon, and we got a good result. So where your stent really doesn't track, this is one more place where you could use a DCB very effectively. So friend, so de novo large vessel disease, we need more studies. And one study that we had, the cage-free study, unfortunately did not show non-inferiority of DCBs over DES. Bifurcations, we can reduce the metal load, avoid the metal load completely. Ostial lesions, obviously it's really great. Long diffuse disease, you should not stent for sure. Use DCBs or leave them alone. Hybrid approach is a good approach. Again, in calcium, spot stenting, and where you can't really deliver a we saw all these cases, and the take-home messages are already clear. Clinical indications of DCBs, need to be evaluated further apart from the ISR and the small vessel. But, we are competing with DES, so, which is a high bar. Now, there's only very limited data, but we must be cautiously optimistic in order to broaden the clinical indications of technology. Now, we need larger studies with a longer follow-up. Remember, I think the cage-free trial was for 2 years. So DES is going to, they're going to mace rates as the years progress. Longer follow-up with DCBs where you have not, there's no metal in the artery, the mace rate is actually going to decrease over the years. So I'm sure the DCBs are going to catch up with DES and maybe eventually better. And let's hope so. Despite all this, how many of us are actually using DCB here? In fact, in the Oriental world, in China and Japan, it's about 20%. In UK, it's about 8%. I don't think we have data here in India. But at our hospital, 8% of all DCB, of all PCIs that we are doing, we are now using DCBs. Now, again, stenting, the reason why we are not using DCBs too much is the time and the effort involved in doing a DCB. You spend at least 2 to 3 times the time that you do a DES. For a DES, you pre-dilate, you stent, post-dilate, out. It's like bang, bang, bang. But for a DCB, you have to be patient, you have to prepare your lesion very well, you have to image, and you have to only apply a DCB once you are sure your preparation is good. In fact, I was just talking to Florim, and we end up, I said, it's really painstaking, but you really enjoy the process. I feel, doing a DCB is an art, while doing a DES is more of a technique. So I just, just mentioned to Florin that it's like, having, putting a DES is like, maybe if he said I can use, I can actually quote this, is using a DES is like having sex, but using a DCB is like making love.